Today's topic, I was afraid it was to some extent overlapped with Dr. Muratori's lecture, but I'm very happy it's not. So I will take the lead from where she left the previous talk. And the aim is to talk about DNA fragmentation in general, the causes, how to measure it, just an overall view of this stuff because she nicely addressed this part in the previous lecture. But mainly I will try to focus on the evidence behind the use of DNA fragmentation tests when implemented to forecast fertility and the results and outcomes on IVF and ICSI cycles, trying to kind of provide with some recommendations about who should be tested and what to do with the results. And this is not easy because there's a lot of information, very confusing in some cases, that I try to some extent, bring you in an intelligible way. Right? So first, what's DNA fragmentation, who causes it, and why it's important? There are different types of harm to the DNA in spermatozoa. Initially, DNA fragmentation is the break of DNA strands into smaller pieces, but there are different other types of harms on the DNA of sperm that can be to some extent put in the same box as and concept of DNA fragmentation. It is divided typically into single-stranded and double-stranded breaks, but again, there are different approaches to measure them, and there are different causes for each type of DNA harm in spermatozoa. There's a number of causes that may be testicular mechanisms, post-testicular mechanisms, some exposures, including, a number, disease, life habits, oxidative stress, poor diet, alcohol, smoking, etc., etc., etc. So there's a first message to deliver, which is there are a number of circumstances that may impact on DNA fragmentation in spermatozoa. So this is kind of the first take-home message. The second is, why do we think it's theoretically important? Well, from the physiological viewpoint, given that sperm DNA will be delivered to the oocyte to create a new embryo that will implant and finally end up being a healthy child, it's reasonable thinking that any harm on DNA in spermatozoa may lead to harm also in this process towards having a live birth. But it is not sure at all, because DNA coding part, it's just a minor part across the whole DNA sperm harbors. And this is also important to have it to take it into account. Dr. Muratori did an excellent job on showing how to measure sperm DNA fragmentation. You know that there's a number of different tests that measure different things. Not all of them are measuring directly DNA fragmentation. Others measure susceptibility of DNA to be fragmented under certain conditions. Some measure one type of harm, some others measure a different type of harm. And the point is that correlation is not causation, and correlation does not mean reproducibility or robustness. This means that two things can be correlated, but may bring very, very different results. It's a statistical circumstance. You can have some test giving a result which is 3 times the other result, and this correlates perfectly, but this is not measuring exactly the same, right? So this is kind of tricky. The main point of this lecture is about how DNA fragmentation is related with reproductive outcome. Which outcome? Which outcome do we want to measure in relation with DNA fragmentation stent in sperm? Because there's a number of papers showing results on different stages across the entire assisted reproduction process. There are studies focusing on sperm quality, on fertilization, on embryo development, on embryo quality, on embryo transfers outcome. So it's not easy measuring things. And this is the first and most important slide showing why do we feel, or at least why do I feel so confused when analyzing DNA fragmentation results. The point is that this is a table including results from different studies where the outcomes on IVF and ICSI are trying to be correlated with the extent of DNA fragmentation in spermatozoa. And it's very easy to see that first, there are different tests employed, so probably you cannot conclude all things exactly in the same way from the different tests. The effect size of each study may be very, very, very different. What do I mean with effect size? I mean the importance of having DNA fragmentation on the reproductive outcome. So there are studies showing something like it's like 10 times most better results with integer DNA in comparison with altered DNA. There are others which is only 2 times, others 5 times. And the most important thing, there are some papers that find nothing, or even, and this is a curious thing, having better results with high DNA fragmentation, which does not make sense at all. So it's very important to pay attention to the numbers, because when you evaluate a diagnostic tool, you tend to measure kind of sensitivity, specificity, and this kind of statistics, and the area under the curve, this kind of statistic measurements showing how good is a particular test to forecast some outcome. And in this sense, you can see that different studies may provide very, very different results. So overall speaking, the influence of DNA fragmentation, it's impossible to evaluate. I cannot give a definitive, a conclusive answer on the influence of ART. People tend to rely, sometimes by mistake, on the results of meta-analysis. And I came here with just some of them, not to pay too much attention, but to get the overall message. So this is one meta-analysis made in 2006, where pregnancy, ongoing pregnancy, and live birth were evaluated, and they found that the probability to achieve a delivery on DNA fragmentation index below 30% was 7 times better than having a worse DNA fragmentation scenario. In 2006, there are other papers in a similar way, showing not exactly the same results, showing that fertilization rate was equal, clinical pregnancy rate was lower on high tunnel assay positive spermatozoa. In 2007, another study with different studies included on the meta-analysis showed slightly different results, kind of finding this association on IVF but not on ICSI. In 2014, again, there's another study that seemed to confirm a little bit more the relevance of these studies on ICSI cycles instead of IVF. But embryo quality seemed also to be, to some extent, affected. But the main problem with the meta-analysis is that they are only valid until they are published. This means some meta-analysis published in 2006, it's almost 20 years old. This means in these past 20 years, the pace at which DNA fragmentation analysis studies have been published have changed the whole picture a lot. So regarding pregnancy loss, this was a very, very important, because methodologically it was perfectly done and also included a lot of information at that time, 2008. And the message was more focused on the outcomes of miscarriage in the cases of high DNA fragmentation. But again, they all seem to be very, very old and not actual in the light of the current evidences that we have on our table. This is, to me, the most recent and the best executed meta-analysis, and this is important because this comes from one group that is providing with this kind of tests, and they already published the correlation between the double-strand breaks and reproductive outcomes. But when they run a meta-analysis with the most up-to-date information, they were not able to find any correlation, not with IVF, not with ICSI, not with any kind of insemination procedure, on the live birth rate obtained, regardless DNA fragmentation levels in the spermatozoa they employed for the IVF or ICSI treatment. So that's where we are now, about where we are now. I think the best thing you can do that's what I would recommend, is checking your own information. And we have a lot of experience in this. We published a number of papers on DNA fragmentation, on the predictive value of this test, on how this relate with some diseases and exposure, like smoking, like having repeated miscarriages, as having cancer, and so on. And to me, this is a test that should be just required in very particular occasions and not broadly offered to our patients. Which are the main problems I found when interpreting the studies relating DNA fragmentation with reproductive outcomes on IVF or ICSI? Well, first, as I said, DNA is not entirely coding. So it's only 3%. This means one break can do nothing, and several breaks can be doing nothing because the probability of having a random break doing any harm or inducing any kind of pathology, it's very unlikely. But the difference between the studies that are published is that they study different populations, different kind of sperm analyzed, either raw spermatozoa or prepared spermatozoa. So the time that has passed between the ejaculation and when the sample was analyzed is not controlled in many of them. The main outcomes measured are very different. Some of them go just for biochemical pregnancy, some others for clinical pregnancy. Very few go further to live birth. Which are the techniques to detect the DNA harm? There's a number of different techniques. Then also there's confusion about which kind of ART are you studying. It's not the same case with ICSI, with IVF, with IUI, with natural conception. So are very different scenarios. One prognostic test can work in a specific population for a specific scenario and not in others. And there's an important thing that probably we will go in depth afterwards, which is almost no study is considering the contribution of those embryos that were not transferred in the first place. We know that when you conduct an ovarian stimulation, you get many oocytes, you fertilize all of them, then you get a number of embryos. But all these studies try to correlate DNA fragmentation with the results obtained with the first embryo transfer. And there's nothing about the remaining embryos. And this is a huge bias. Why is a bias? Because you are comparing the smartest guy in this room with the smartest guy in another room. You are not comparing the average smartness of both rooms. Do you follow the idea? I will show you some numbers supporting this. There's another important issue with the threshold values in order to say something is normal or abnormal. You can see in the literature that the threshold to label a sample as abnormal regarding DNA fragmentation may vary between 15%, 25%, 30%, 50%. It depends on the study. So you are not making them comparable. It's a very, very different issue. Many studies are not blind. Different studies show different effect size. And another very important issue for me is that almost none of them are controlling the female factor contribution. So the exposure, it's DNA fragmentation. The outcome, it's something like ICSI result or transfer and so on. But there's no statistical control nor aleatorization that can guarantee that the female are comparable also. So it's a relevant bias that it's only adding confusion to how we interpret the results. So the recommendation, again, if you run this kind of analysis in your business, please check your data. And then you will see if this is predictive for you, then go ahead, it is. If it's not, then abandon the stuff. Check your own numbers. And that's something that we did. And we did it I think in a different way, which is, let's count how many oocytes, how many embryos transferred, and how many embryo transfers do we need to get a child depending on the levels of DNA fragmentation. And this is done through the analysis named survival curves and the Kaplan-Meier statistical approach. So It's important, and this was a paper that we published with Irene Hervás, one of my PhD students, where we showed that the classical way of analyzing and comparing DNA fragmentation levels with reproductive outcomes showed no differences at all. But when you represent the number of transfers needed in own oocytes or donated oocytes, when you represent the number of embryos that have been transferred and how the cumulative rates are described, and the number of oocytes that you need to inseminate in order to get the first child are absolutely the same, regardless DNA fragmentation levels. So it takes the same getting a child independently of the DNA fragmentation, accounting for all things, all embryo transfers, until you finally succeeded or you abandon the treatment. So this is a different approach about measuring these kind of things. So the same things were done using donated oocytes, as you can see in these slides. So the conclusions for us, it's okay, in the literature, DNA fragmentation seemed to be linked to a little bit worse clinical results, but honestly, I don't know by how much. I cannot tell. So what do we do? Well, there are some approaches in order to decrease DNA fragmentation, expecting an improvement on the reproductive outcome. But if we say that they are not so correlated, do they work? Well, again, you can tell patients to avoid exposures and change life habits in order to diminish the risk to have, this is for free, and this is for good for them. This improves the health. Let's see, it's kind of empirical, but that's fine. But the other ones are patients are charged for them, including MACs, microfluidics, TESE, blah, blah, blah. So we need to pay attention to this. Concerning magnetic activated cell sorting, at the very beginning, there were cases reports, then non-randomized trials, then some RCTs, then some meta-analysis, but the overall message, even from the Cochrane review database, is that it's doing nothing to improve reproductive outcomes. And we measured it in a similar approach. Those samples treated with MACs versus those samples not treated with MACs, and the number of embryo transfers, embryos transferred, and the number of metaphase 2 oocytes needed to get the first child were exactly the same. Exactly the same. So it's doing about nothing, right? There are some other papers focusing on, for instance, hyaluronic acid ability to bind the sperm and so on. This is a very nice trial conducted in the UK, showing that it seems to alleviate the risk of miscarriage, but this is not translated into higher live birth rates, at least not with this sample size. Probably with more cases this can be reflected, so kind of preliminary. And we published these two papers, mainly this meta-analysis, where interestingly we were able to confirm in a limited number of studies that picking spermatozoa from the testicular tissue on those cases with high DNA fragmentation and the first ICSI failed increases by 2.4 the odds ratio of having a child, which is at least something to pay some attention. In fact, we are currently updating this information because it was published in 2017, and with 3-4 more studies, results remain the same, are about the same. Microfluidics has emerged as a very, it seems in the IVF laboratories, a very practical technique because it avoids handling and it gives you some speed on processing the samples. It seems also be decreasing DNA fragmentation, but there are few and not very well designed studies showing that this is improving the end reproductive outcomes in order to bring more children at home. Regarding the offspring health, there's some animal information, animal experimentation. It's very rare. We published a paper recently showing that obstetrics and perinatal outcomes were about the same, regardless the DNA fragmentation level exhibited by the male at the time they delivered the sample for the IVF treatment, which is in agreement with this Chinese group I'm showing here. This is our paper. measuring, gestational age, the size, the weight, and all the parameters that have been described in order to follow them. So in conclusion, does it really matter? Well, it depends how much it costs. If it's 1,000, if it's $20, then maybe we can check for this. So this is in agreement with ASRM, with ESRE, with some societies' reflections on this topic. And for me and for them, seems that existing data do not support a consistent and strong relationship between DNA integrity and reproductive outcomes, including obstetric and perinatal results. At present, they alone, and this is also on the line Dr. Muratori said in her previous lecture, so it's very weird that only one parameter can predict the reproductive outcome. Well, it does not predict pregnancy achieved through ART or natural conception, so there's insufficient evidence to ask every patient for this. So it's related with male infertility but not predicted, should be suggested in the case elevated risk is detected, not for everyone. When additional info is needed, probably if you have 1 cycle, 2 cycles, unexpected bad embryo quality, you don't know what to do, then you can get some more information, but it's not the only reason to take decision. So I wanted to thank my team and inviting you coming to Valencia anytime you're there to visit us, and I will be happy to take any question